Our next speaker is a fellow Brit that I've known for a while. His name is James Bennett. He's a perfusionist at Liverpool Heart and Chest Hospital. He's a Kidney Research UK funded researcher, which is always great to see somebody else getting into the academic world. Data geeks, as we like to call ourselves, I suppose. So it's a pleasure to welcome him across here, and he's going to really talk about kind of the renal implications in these cases. So James, welcome.
Good morning, everyone. It's an absolute pleasure to be here today to talk to you about kidney protection during surgery on the thoracoabdominal aorta, and to answer the question, how can we achieve superior renal outcomes? And this is as a result of a systematic review that myself and some colleagues produced last year. So we tried to answer a few questions as to what systemic perfusion strategies and direct renal perfusion strategies we should be using at our hospital. So first and foremost, I'm a perfusionist and I work at Liverpool Heart and Chest Hospital. But somewhere down the line, I've kind of accidentally fallen into research, which I never planned for. But I'm also here now as a fellow of Kidney Research UK, who do fund my research. And I'm studying a PhD at the University of Liverpool. So what am I going to talk to you about today? Well, first of all, surgical repair of the thoracoabdominal aorta. So what it is, why it may be necessary, and how we perform that at our hospital. Secondly, the complication of acute kidney injury, which I'm sure you're all aware of, but I'll briefly recap the issues around acute kidney injury and how that may develop. I'll talk about a systematic review that we produced last year and how this was conducted, so which is really a process of analysing all of the evidence out there in the published literature to try and support what we do clinically. And finally, what I found from reviewing the evidence. So what systemic perfusion strategies, selective renal perfusion strategies, and blood management techniques are supported by the strongest evidence in the body of literature that is out there. So the thoracoabdominal aorta, you're probably all aware, but it's the aorta that extends distal to the left subclavian artery and goes all the way down to the iliacs. So it's above and below the diaphragm. In the presence of an aneurysm, when those aneurysms grow to a diameter of above 5.5 centimeters, surgery is recommended. And without surgery, patients are at risk of dissection and rupture and visceral organ ischemia. And when the risks of not having your operation outweigh the risk of surgery, that is typically when this is undertaken. But they are often asymptomatic, which is why they're sometimes branded as silent killers. And you can see on the right there, we've got a repaired aorta. That was an extent 2 thoracoabdominal aneurysm that was repaired at our institution. And you can see that the whole aorta has essentially been replaced with a Dacron graft with side branches to the different visceral arteries. Now, we all as perfusionists know about acute kidney injury, but just to recap, within 7 days of surgery, we might see a decrease in urine output, retention of solutes and urea in the blood, and it's typically diagnosed by an elevated serum creatinine concentration. And when that is tripled, we are in the territory of severe acute kidney injury. And patients at that point will need to have at least temporary hemodialysis to restore their blood gases. So several years ago, when I began to get involved in these types of operations, I began to get a bit frustrated because I would speak to one of our surgeons a couple of days after having a really intensive operation, and I'd ask how the patient was, and inevitably it seemed to be, yeah, the patient's doing fine, they're awake, oh, but they're on dialysis. And this, oh, but they're on dialysis kept on coming back again and again and again. So I thought, let's look into it. So we're lucky, I mean, we've talked a lot about data already today, but we're lucky at our hospital that we were one of the first digital trusts in the UK. So I could go back all the way to 2009 and I could pick out from our patient records, not just some operative characteristics, but also some patient outcomes. And I found that over half of our patients who had this operation had developed acute kidney injury, and a third of patients required hemodialysis. So at the time, we were using left heart bypass and cold renal blood perfusion to keep these patients alive during surgery. But I began to ask the question, is there a better way to protect patients from AKI? And that led to the production of my systematic review. Now, if anyone's unaware of what a systematic review is, well, so was I up until a couple of years ago. If you're anything like me, when you did your undergraduate or even your master's studies, if you were given an essay topic, you'd often try and find some arguments to support what you believed, some to refute, and then somehow you'd come to a compromise in your discussion and conclusion. Well, a systematic review is quite different to that, and it's a way of trying to answer a certain question in as unbiased a way as possible, and to lay out the steps that you undertook in that process, so anybody here in the audience could try and replicate those steps and hopefully reach very similar conclusions to what I have. So step one is a literature search. Myself and a colleague, Sarah, performed this. We tried to find all papers published between 1995 and 2024, which featured thoracoabdominal surgery and reported renal outcomes. And we found 624 studies. However, we then took every single one of these papers and we screened them by the title, the abstract, and the full text to make sure that we were only including papers that included primary research. So the research was undertook on patients. It wasn't a review of previous data. We wanted an adult patient population, the use of some kind of perfusion, and a good report of renal outcomes. And after screening out 579 studies that weren't appropriate, we were left with 45. So with 45 papers on the table, how do you then decide which evidence to use to support the outcomes? So we conducted a quality and risk of bias assessment. So essentially put every single paper through 10 predefined quality questions, and we could then categorize those on the basis of how strong the evidence was, how well was that study performed. And finally, we could extract the data from those studies and use those papers that we deemed to present the highest quality evidence to structure that narrative synthesis. We initially wanted to create a meta-analysis of the data, but unfortunately, as I'm sure you're all aware, in perfusion, we've got lots of different studies that feature heterogeneous populations, lots of different perfusion techniques, lots of different ways of diagnosing acute kidney injury, and so it wasn't really appropriate for us to perform a meta-analysis, unfortunately. So when it came to data extraction, what did we want to find out? So we looked at every paper and we took out things like the sample size, like the patient characteristics, so how old the patients were, what the gender split was, what extent of aneurysm had been operated on. Was it just extent 1 aneurysms, which don't actually involve the renal arteries, or was it extent 2, which is from the left subclavian all the way down to the legs? What perfusion techniques were used? So what systemic and kidney perfusion strategies might have been used by the perfusionists? How acute kidney injury was diagnosed, and what proportion of those studies may have featured emergency surgery as opposed to elective? So the first question we wanted to ask and answer was, what techniques can we use as perfusionists? And what we found was that typically we have two main types of systemic perfusion strategy, and these essentially are decided upon on the basis of whether a surgeon can place an aortic cross clamp on or not. So if there's no ability to place an aortic cross clamp, we have good old-fashioned cardiopulmonary bypass and deep hypothermic circulatory arrest, which can then be augmented in some cases with some perfusion of the renal arteries with cold blood or cold crystalloid solutions. If you can place a cross clamp on the aorta, then you've got two choices of distal aortic perfusion strategy. You've got left heart bypass, which is the delivery of oxygenated blood from the left side of the heart to the distal aorta, or partial cardiopulmonary bypass, which is when we take out venous blood, we oxygenate it with an oxygenator, and we return it into the distal circulation. And again, that can be augmented with cold blood and cold crystalloid renal perfusion, or with warm blood renal perfusion as well. And what we found was when we broke down every single study subgroup by the perfusion strategies used, just over half used left heart bypass, and a third of those used cold crystalloid renal perfusion. So that seems to be the most common strategy, left heart bypass, cold crystalloid to the kidneys. But we did see 7 subgroups that included just simple aortic cross-clumping, which is quite a historic technique of just placing a cross-clump on the aorta and stitching as quickly as possible, sometimes augmenting kidney protection with some hypothermic solutions. We saw 13 subgroups that featured circulatory arrest and 12 that featured partial cardiopulmonary bypass. So I mentioned we wanted to analyze what the quality of evidence was in each paper. So what level of confidence can we put into the findings of each of the 45 studies? So the ideal study would be prospective. It would recruit patients in advance. There'd be a defined study protocol. It would be comparative, so it could compare one technique to another, or maybe even a third technique. We'd have a low heterogeneity, so patient cohorts would have similar characteristics such as age. We'd have large sample sizes recruited over a short time frame. We'd have appropriate statistical analyses, no duplication of patients across studies, and no potential conflicts of interest. So you can see on the right there, there's a table of every single paper that's been passed through our 10 quality questions. And sadly, 5 studies we deem to be very high or high quality, which isn't really a big surprise in the history of perfusion, especially given that this was a really emerging type of surgery in the mid-90s. We found 9 studies of moderate quality. So these were typically studies that were potentially observational, retrospective, maybe included one cohort, and had some kind of statistical analysis. But unfortunately, 31 were deemed to be low quality, small sample sizes, typically retrospective, with potentially some inherent bias towards patient characteristics. And this isn't to say that those researchers or clinicians did a bad job. It's just to say that there was potentially an urgency to get some research out on a certain topic. And unfortunately, they just didn't fulfill our 10 quality questions. 7 studies were also removed due to duplication, as we found that some patients were included in more than one paper, so that could overrepresent how good a technique or how bad a technique was at protecting kidneys. So the big question, how can we achieve superior renal outcomes? Well, what we did was we took our highest quality papers and we broke down some of the main findings. And the first thing that we found was that the strongest evidence supports left heart bypass with renal cooling. So again, left heart bypass is the shunting of oxygenated blood from the left side of the heart to the distal aorta. So in those cases where patients had aneurysms that were quite high up in the descending thoracic aorta, or extent 1 aneurysms, then it's no surprise that left heart bypass can protect the kidneys pretty well, because essentially it just means that the kidneys don't face any ischemia during their operation. They also left heart bypass can be adapted for selective renal perfusion. So for those larger extent aneurysms, we can augment that kidney protection. So we can deliver left heart bypass flow to the distal aorta whilst we're giving crystalloid or blood perfusion to the kidneys. And then as the surgeons can move their cross clamp upwards, we can reintroduce blood flow to the kidneys quite quickly. So in 2002, Coxey and colleagues found that they could achieve a 0% incidence of acute kidney injury with left heart bypass and cold crystalloid selective renal perfusion. 7 years later, Lemaire and colleagues found that cold blood and crystalloid solutions were equivalent at providing renal protection, with only a 3% incidence of acute kidney injury in both groups, and there was no difference in operative mortality. Then more recently, Karlberg et al. In 2021 showed that custodial selective renal perfusion was superior to Ringus-based crystalloid perfusion solutions, leading to a decrease in the rate of acute kidney injury. So really we have this theme of left heart bypass plus some form of cooling of the kidneys, potentially using cold crystalloids. The second thing that we found was that warm blood renal perfusion was not supported by the evidence. So this seems quite strange, because on one hand I'm saying that left heart bypass is good for the kidneys, which is providing a normothermic flow of blood. And theoretically, we might think that providing a good DO2 to the kidneys is what can protect them. After all, we're all interested in goal-directed perfusion. But when you look at the studies that included warm blood renal perfusion, we find that potentially they weren't giving enough blood flow to the kidneys. Maybe that DO2 wasn't high enough, but we didn't know about DO2 back when these studies were performed. So the kidneys typically receive 1.2 litres of blood flow per minute, which is around a quarter of all cardiac output. In 1996, Safi and colleagues showed that warm blood was associated with a 4-fold increase in acute kidney injury compared to left heart bypass alone. But the mean collective blood flow in this study was only 250 mils per minute. Again, in 2002, Cox et al. Showed that warm blood was associated with a 3-fold rise in acute kidney injury compared to cold crystalloid perfusion. And again, the mean blood flow here was 300 mils per minute per renal artery, so a bit higher, but not what the kidneys are used to. And in 2004, Hassoun showed that warm blood kidney perfusion was associated with increased operative mortality. So really, there was, again, a trend away from warm blood kidney perfusion at this time. But what's interesting is when we look into ex vivo normothermic kidney perfusion for transplantation at the moment, we see a different course. We see that clinicians and scientists are now re-looking at normothermic kidney perfusion for different reasons, not just to protect the kidney, but also to be able to assess how well a kidney might still be producing urine prior to transplantation. But we are seeing that, for instance, in 2019, Weisenbacher et al. From the University of Oxford could perform normothermic perfusion of kidneys for 24 hours and still have the kidneys producing urine and removing serum creatinine, removing creatinine by the end of that. And just last week, Pebble Biotechnology Laboratories in Cheshire in the UK have actually achieved 50-hour normothermic kidney perfusion sessions, where again, they say that the kidneys were looking pretty healthy, passing urine and removing creatinine after that time. So clearly there is an ability for us to maintain some kind of normothermic protection of these kidneys. Potentially we just didn't achieve that in the 90s and the early 2000s. Maybe it's something we need to look at again. Of course, there are caveats here. There's no way of using these normothermically perfused kidneys in the body. These weren't clinical studies. We don't know if those were then transplanted into a patient. Would those patients have delayed graft function? It's not really that comparable to acute kidney injury. However, there is some potential there, and I think we need to do some research on this. The third point that we found was that deep hypothermic circulatory arrest is supported by weak and biased evidence. Now, this isn't to say that it's a bad technique and it shouldn't be used. In fact, when you look at renal outcomes following deep hypothermic circulatory arrest, we can see really good levels of kidney protection and low rates of hemodialysis. However, we just can't confirm this from the quality of evidence that was available to us. And in the wider context, we need to consider more than just the kidneys. We need to think about bleeding risk. We need to think about neurologic injury. And really what we need is a high quality study that can compare deep hypothermic circulatory arrest with left heart bypass or alternative techniques. So if anyone does have that data out there, please do produce a high quality study on this so we can put the argument to bed. The final point that was obvious to us was that reducing hemolysis may contribute to better kidney outcomes. Now, we all know as perfusionists that lots of high vacuum suction, turbulent flow, and occlusive rollers cause damage of the red blood cell membrane, which releases what is ordinarily something that we want, hemoglobin, to be transported through the blood, but it releases it into the plasma. When it's in the plasma, free hemoglobin can scavenge nitric oxide in the renal vascular endothelium, which can mean that we have some dysfunction of the arteries in the kidney, and they might not have the same ability to dilate in that short period of time after surgery. So it may contribute to a form of ischemia. The downstream product of hemoglobin, heme, and also free iron can also produce oxidative stress, which can potentially cause damage to the kidney. And finally, all of that free hemoglobin can contribute to the inflammatory response. In 2010, Vermeulen, Winsant et al. Showed that there was a relationship between the total plasma free hemoglobin release after aortic surgery and urinary NAG excretion, which is a marker of kidney injury. And in 2022, Kaiser et al. Showed that the the greater the volume of blood that was returned to the cell salvage system and returned unwashed into the patient's circulation led to a higher probability of those patients developing renal failure. So there is some evidence that damage to red blood cells over an extended period of time may contribute to poor renal outcomes. So we now have a bit of a picture. We have a picture of ischemia reperfusion injury. So we know that longer cross-clamp times, longer renal ischemia times can contribute to acute kidney injury. And we know that if we cool the kidneys down, we can reduce the consumption of oxygen and potentially allow some protection. And we know that reinstating blood flow to the kidneys early or ensuring it's present through the entire thoracoabdominal operation is beneficial to prevent ischemia. We know that hemolysis may contribute to ischemia reperfusion injury, and it may also contribute to inflammation. And as a result of these three processes, we've got oxygen-free radical generation, endothelial dysfunction, and vascular occlusions, which can all contribute to AKI. So what are my take-home messages? So firstly, all techniques may be used to achieve good rates of AKI. I'm not here to sell one technique versus another. But what was clearly emerging from the evidence from the systematic review was that left heart bypass and custodial selective renal perfusion are supported by currently the strongest evidence. Now, there are some caveats to that, which is that we all know that custodial is a cardioplegic solution. We don't want to use too much of it during these operations, particularly during left heart bypass. We want the heart to continue to beat, to perfuse the brain, to oxygenate the blood. And if you gave too much custodial, potentially you'd start to see some ECG changes. And we don't currently have a paper or any guidance on how much we should be delivering to patients to prevent these from occurring. So although it's supported by the strongest evidence for renal protection, I think we are, as a group, in want of some further guidance on this. The second point would be kind to blood. So we take red blood cells, we take them, we wouldn't be here without them. Our jobs depend on them. We need to be kind to them. And the more that we cause damage to them, the more likely we're going to see worse outcomes for our patients. So if you can, make sure you use an appropriate cannula. Try and turn down your vacuum negative pressures as much as possible. And just be kind to blood. And finally, please get engaged with research. The only clear point that emerges from this review is that we don't really have that much evidence to support any of our techniques. As I mentioned earlier, I've fallen into research by accident. It was never my intention, but now I can see the value of collaborating with researchers at universities, clinicians in other centres. Going to meetings like this is exactly what we need, and we need to think we're all capable of it. Reach out to your universities, ask your hospitals, is there any money that's available for us to have even some software that we can look back at some retrospective data, and please just get involved. And that's everything. Thanks for listening.